welcome everyone. It is my pleasure to introduce Dr. Martin Bretzner, who is an interventional radiologist from France and has been here as a postdoctoral research fellow in the Kistler Stroke Center under the mentorship of Natalia Ross. And we thought Martin's work was particularly interesting to this group because he has been extracting data from routine clinical MRI images of stroke patients to start to examine how you can calculate radiographic age, if you will, or determine patient age or biological age. Anyway, he's going to go through all of that. He's got a terrific paper that is, I think, recently accepted on this topic. So Martin, what we'll do is we divide the hour between the two speakers. So if you could, give yourself about 20-ish minutes, so that'll give us time for a lively discussion, questions and answers. So Dr. Bretzner.
Sure. Thank you for the kind introduction, Dr. Rosen. So I'm gonna go ahead and share my screen. Can you all see it?
Yep.
Yep.
Okay. Thank you. So my talk is entitled Radiomics Brain Age, a Novel Imaging Biomarkers of Brain Health in Acute Stroke Patients. And so according to the WHO, aging is at the biological level, the accumulation of several molecular and cellular damage over time. But more interestingly, what is stated on their webpage is that those changes are only loosely associated with the person's age in years. And so what it means is that we all, for us, time passes at the same time, at the same speed for everyone, but we all age at different speed. And so what it means is that at the biological level, those changes accumulated at an expected and normative pace. And that what it also means is that some people will accumulate those changes less rapidly and will present healthy aging, while others will have more damage over time and will present accelerated aging. And so there's a different field that tried to tackle the question and to infer biological age, either from clinical examinations with cognitive function, with cardiovascular function, with motor function, also using biological biomarkers such as inflammation biomarkers, cardiac biomarkers, or hormones. In the radiology field, and it's mainly was the topic of predilection was brain age, which I'm going to present today. But it also you can do also biological age using liver function and kidney morphology. One of the field that's been very active into inferring biological age is genetics, studying telomere length or methylation, for instance. So for the brain age literature, people actually predicted from the MRIs or CT scans or image from the brain, the aspect of the brain, and trying to predict what age does it look like. And they analyzed the deviation from the chronological age of the patient, and that's been called brain age difference, predicted age difference, brain age, and brain age delta. And they used that biomarker to analyze personal risk factors and diseases. And in the general population, it's been shown to be associated with a wide variety of global health markers such as grip strength, lung function, walking speed, intelligence, and cardiovascular risk factor, which all together led to increased mortality risk. And in the neurodegenerative diseases have also been studied, especially in Alzheimer's disease, and it's been shown to be an independent predictors of the conversion from MCI to AD, regardless of the ApoE status. It's also been studied in psychiatric disorders, patients with schizophrenia, suffering from schizophrenia, had older looking brain, and even people with only a first episode of psychosis had older looking brain. And at the individual level, patients' individual cardiovascular risk factor were also shown to impact brain health. A patient with suffering from type 2 diabetes had older looking brain. Patient with metabolic syndrome had older looking brain, and it's been shown to be associated with poorer liver and kidney function, prenatal malnourishment, and alcohol and tobacco consumption, and even traumatic brain injury, past medical history. But so there's also predictive factors such as meditation. They compared brains of meditators to brains of non-meditators, and at age 50, some authors showed that brains of meditators were looking 7 years younger than brains of non-meditators. And playing music seems to be a protective factor, especially if you do it for leisure. So it's not grim. Regarding matter and stroke, there's only very few manuscripts that studied brain age and stroke. And basically what authors have shown is that stroke survivor had older looking brain, and patients that had also older looking brain were more at risk of developing a new stroke. So patients are kind of stuck into this vicious circle of new strokes when they had ones, because they have stroke, they have older looking brain, and then they develop new strokes. However, the impact on stroke outcomes remain unknown. And I think one of the problem for inferring brain age in using brain age into the stroke field was the method they use that's been traditionally used. There's quite a lot of pre-processing steps that heavily rely on T1 weighted imaging, which is not actually acquired into when you do acute stroke MRI workup. During an acute stroke MRI workup, you generally acquire diffusion, T2 flare, susceptibility, or T2 star, and time of flight, or any vascular imaging. And among those candidate sequences to study brain health, I think one is particularly interesting, and that one is T2 flare. So, for example, if we look at those 4 patients from the MRI cohort, which is the cohort we studied, those are 4 patients that suffered from a stroke. And on those, we can see that they have all varying degrees of atrophy, varying degrees of ventricular shape and size, different loads of white matter intensities, and maybe different sharpness of definition of cortical and subcortical structure. And if I say that the first patient is 35 years old, and the second one is 50, the third one is 65, then the last one is 80, no one's going to be surprised, because this is probably what would be close to the expected and normative brain aging that we all know. But and if I say that there is a gradient of likelihood of good functional outcome favoring patients that are younger, no one's going to be surprised, because it's very well known that age is has a huge impact on the post-stroke functional outcome. But now, if I say that the first patient is 80, and the second one is 65, and the third one is 35, and the last one is 50, would that gradient of likelihood of post-stroke functional outcome still holds? Should we trust more chronological age, or should we use a more personalized biomarker for brain health in those stroke patients? And so, stemming from this hypothesis, stemming from this consultation, we formulated 4 hypotheses. First, the texture or the appearance of the T2 flare MRI can predict brain age. Second, we would observe a higher brain age in patients with cardiovascular risk factors. Third, that brain age would be a surrogate marker of microstructural integrity. And lastly, that patient with a higher brain age and older looking brain would have worse post-stroke outcome. And so to do this, we leverage the MRI Gini cohort, which have more than 5,000 MRIs from stroke patients all over the world. And we looked at the T2 flare imaging, and we extracted radiomics features, which are standardized descriptor of the image that are automatically extracted. And basically, we extracted 760 variables per patient that are descriptors of the appearance of the T2 flare. So its shape, its intensity, is there like zones that are looking coalescence of hyperintensities, and so on and so forth. And from those 760 variables that describe the appearance of T2 flare imaging, we built a machine learning framework to predict chronological age using only those radiomics feature, and ended up with, for each and every one of the patients from the cohort, we had a predicted age for those. And after correcting for a regression dilution bias, which is common in the field of brain age, we ended up having this relative brain age biomarker, which describes the appearance of the brain in comparison to the other members from the cohort. So patient on the top side of the plot, patient with positive relative brain age, those patients have brains that are looking older than the other one from the cohort on average. And on the bottom part of the plot, the patient with negative relative brain age have brains that are looking younger than the other peers that are age matched within the cohort. And so to give a sense of how it works, we're gonna play a little game. So I'm gonna show you two brain scans, T2 MRI, and then you're gonna type in the chat how old do you think those patients are. So here's the first one on the left. And I'm gonna play the second one on the right, and you can type in the chat how old do you think those patients are. Play it again. Yeah, patient on the left seems younger. Left 55 and the right 85. Yeah, so basically everyone thinks that the patient on the left, notwithstanding the huge MCA stroke, left MCA stroke, but notwithstanding that, everyone thinks that the patient on the left is younger than the patient on the right. And so our machine learning framework thought the same. So the predicted age for the patient on the left was 43, and for the patient on the right was 88. However, their real age was for the patient on the left 92, and on the patient on the right 46. So I guess we all know which brain we want to have when we're going to be 92, if we get to that state. And so, how could we explain those differences in the appearance of the brain? So we try to see whether this relative brain age biomarkers was impacted by individual cardiovascular risk factors. And so we analyzed this relative brain age biomarker according to the presence or the absence of cardiovascular risk factors, and we showed that patients with hypertension, diabetes, AFib, coronary history of smoking, and prior stroke all had positive relative brain age and therefore older looking brain. In multivariate analysis, patients with hypertension, diabetes, history of smoking, and prior stroke all had older looking brain. And the most detrimental factor for having an older looking brain was stroke, with that had a negative impact threefold more severe than the second risk factor, that was diabetes. And so now that we can predict relative brain age from radiomics, from T2 FLAIR, and that it kind of sums up the cardiovascular and brain health of the patients. What does it mean at the microstructural level? What does it mean at the microscopic level? So on a subset of the cohort, we had DTI metrics, and we tried to see whether these relative brain age metrics was associated with DTI abnormalities within white matter intensities and outside in the normal appearing white matter. And so on the left, we can see the correlation of those DTI metrics with age, and we can see that they're all well correlated within white matter intensities and outside. Those DTI metrics are correlated with age, and that's known in the literature. This is PSMD, which is a kind of trendy DTI biomarkers that sums up connective DTI on a global brain scale. And for relative brain age, what we show is that it was associated with the abnormalities outside in the normal appearing brain with DTI metrics, and the biomarker that was most correlated with was PSMD. And so looking at the direction of those associations, we think that relative brain age captured DTI abnormalities that were surrogate markers of axonal degeneration and demyelination. So it seemed to be associated with abnormality at the microstructural level, but in the end, does it matter? Did we see worse post-stroke outcome for patients with higher brain age? And the answer is yes. So this is a box plot of relative brain age according to if the patient reached good functional outcome after stroke. On the right, in the blue box, patients that had reached good functional after stroke had a lower relative brain age and therefore a younger looking brain than patients that did not reach a good functional outcome after stroke that had an older looking brain. And so we tried to see if, alongside other known risk factor or determinants of post-stroke functional outcome, relative brain age was relevant. And so we did a multivariate regression, logistic regression analysis using all those cardiovascular risk factor, age, and some imaging biomarkers such as brain and white matter capacity volume, and this new biomarker relative brain age, and of course the stroke severity scale to see if we could predict the good functional outcome. And our feature selection process pointed out that age, prior stroke, and relative brain age and IHSS were good candidate predictors of good functional outcome. And in multivariate analysis, actually, they were all significantly associated with good functional outcome, with NIHSS was still the most detrimental factor for having a good outcome after stroke, followed by the history of prior stroke, age, and then relative brain age. So it doesn't have the strongest effect on reaching a good outcome after stroke, but keep in mind that chronological age is a good quote unquote surrogate marker of brain health, and that it just kind of quantifies the if you are older than your chronological age or younger. And we thought that maybe having good brain health is not always relevant, because if you get hit by a car or if you just fall on the floor, it doesn't matter. Well, no, that's not a good image. If you have a very severe stroke, a 200cc stroke, it doesn't matter if your brain looks 10 years younger or not, you're gonna have a very severe stroke, and that not gonna matter. And so we did this multivariate logistic regression again by including more and more severe stroke patients. And what we showed was that relative brain age had a negative impact on stroke outcome that was most visible for patients with the NIHSS less than 5. So it means that when you have a stroke, if the stroke is not very severe, this is where having good brain health is going to matter. Because if you have a very severe stroke, it does not matter if you have a good brain health or bad brain health, because you're going to get hit by a very severe lesion. And so we try to see whether this association hold on the full ordinal scale of the modified Rankin scale. And what we showed was that younger looking brain were more likely to have a good MRS distribution than their older looking counterpart in the cohort. And so to conclude, Radiomics relative brain age reflects cardiovascular risk factor profile, is a surrogate markers of microstructural injury and improved stroke outcome prediction, and seems to be especially relevant in minor strokes. And I think that's important because those patients that have less than 5 of NIHSS score are not approached for treatment according to guidelines right now. And I think if we could identify patients that have more frailty to say that, oh, this patient, we should maybe do some treatment for him because he's not going to get back on his feet on his own. That could be something very interesting to work on in the future. I would like to thank everyone that supported me, especially Professor Natalia Rost and Dr. Anna Bankov in the Rost lab that did tremendous work with me for that. And so to conclude, I would say that as a French, I would say that age doesn't matter except if you have a bottle of wine or a piece of cheese. And I would like to add, except if you have a stroke. And I'd like to thank you all and welcome questions, if any.
Thanks very much, Martin. If I could ask you to stop your screen share so we can see the group, I'm sure there will be lots of questions. You know, one thing I'd like to just lead off with is I don't know if anyone from Martinos who's worked with Hakan I is on, but you know, there was a series of papers from Hakan I think, and Greg Sorensen and others that first showed that white matter hyperintensity volume was a very potent predictor of how well you would recover from a stroke. And I guess one question for you is how does white matter hyperintensity volume interact with estimates of brain age? Is it incorporated into the measure? Is it simply now that this is a a more complete representation of brain state?
Well, thank you for this question. It's very interesting. So I've looked, we had this phenotype. So I've looked, of course, the correlation between relative brain age and white matter impedances, and we saw that indeed it was correlated. So the higher the white matter impedance load, the higher, the older the patient were looking like. And I tried to analyze the radiomics feature that were most relevant to predict relative brain age. And basically what we show is that patient that had a brain that was not very spherical or not very plump, and patient that had a brain that was a bit more hyperintense in T2 flare were more likely to have a older looking brain. And I think the question is, the answer to your question is a bit there, that if the brain was exhibiting hyperintensity, where it was more likely to have a older looking brain.
So please feel free to either speak up or put your questions in the chat, and I'll make sure that we get to all of them. Well, if there are no other questions, I have one more. Oh, yes, we have a question from De Jong. Does whole body aging and brain aging interact with each other, or are they separate?
So,
studies.
So I did not look if there were interaction between brain age and other methods of inferring age in the literature. I don't know the answer to that question. All I know is that the relative brain age, our biomarker, is completely independent from chronological age, because we just regress out any correlation with chronological age.
Randy?
Yeah, I was just curious. Excellent talk, by the way, and really nice work. I was just curious whether for some of these hundreds of subjects that you have this nice data set on, is there any chance of getting earlier pre-stroke imaging data on any of them, or a sub-cohort, so you could look to see what their brains look like before they experience their stroke, and whether there was an indication of their brain age and or susceptibility sensitivity?
So excellent question. So the MRI as cohort, as you know, is from 17 different centers, and one of the centers is MGH. And I think this is one of the leads that we could use to see whether some of the patients have had prior scans. So I don't know the numbers. I think it's going to be very, very low, but that's something that we could look into in the future. Yeah, that's the gastros cohort. Part of the gastros cohort is within the MRI cohort.
And David Salat has a question about the features.
So what were the
just
features?
Wondering what features you were extracting from the images. I'm sorry if I missed that in the beginning of the presentation. I'm particularly with regard to the fact that these are clinical images and that there's going to be variability across the scans.
Yes, sure. So the scans are very variable, but they were kind of triaged from another postdoc, that Dr. Marcus Shermer, that used to work in the lab, that is working back in the lab actually, that's coming back to the lab. And so he did first a huge task of segmenting all the brains. So some of the brain that were exhibiting most of the motion artifact were excluded because they did not go through quality control of those segmentation. And for the feature extraction part, so we looked at the brain mass on those T2 flare imaging, and we used the toolbox that's called Pure Radiomics by Radiomics, and that extracts Radiomics feature automatically. You just have to pre-specify which kind of Radiomics feature you want to extract. So those are going to look at the general shape, general histogram of the image. They're going to look at whether you have zones of similar intensity voxels that are lumped together or forming lines or co-occurring within the image. So it kind of describes what you see in the image roughly and quantifies it on continuous variable. But I can send you the list of the feature I extracted if you want to use Radiomics yourself.
Sure, thanks. Really nice work.
Rahul?
Hi there. First, great talk. Just a quick question. If I'm understanding the relative brain age, that's the ratio of their predicted brain age from their chronologic age. Is that right? Have you looked at just the absolute, the predicted brain age by itself, not relative to their chronologic age? And
so
how does that do?
So I tried to look at it, but the problem is that it suffers from a bias. So basically, you underestimate old patient and you overestimate you overestimate young patient, and that's the way it used to be in the field. Like 10 years ago, people just use predicted age as the raw predicted age as a biomarker. But since there is some residual correlation with chronological age, I went a step further and removed that, because I wanted to get rid of all the correlation from chronological age, because it was inducing some biases in the analysis. But some of the results holds. But I think since I know that there is correlation with chronological age, I can't use the raw measure.
You might worry that, for young patients who have a certain, predicted brain age, you're going to predict a very large, deficit because they have a very high relative brain age, right? Whereas in terms of outcomes, they might actually be the ones to, better be able to recover because of their younger chronologic age. So, I guess you're going to have to fight the bias one way or the other.
Yeah, I think you're right. But also, like coming back to the example I gave, like this is the 45-year-old woman that had a brain that had significant problems, and I think it of course it is not a good surrogate marker for the whole body age, as someone previously hinted. But I think for the part that is relevant for brain recovery, it's still a add to the chronological age.
Thank
you. One last question, Martin. I think this cohort is almost exclusively or very, very substantially sort of European, white, Caucasian. Is that right?
Yeah. Yes.
So we have to be thoughtful about how representative the study is of sort of the global population. Is this something that one can calculate pretty quickly on the fly, so that it might at some point be part of a clinical assessment that could be integrated into the workflow?
So actually, that's one of the main axes I try to stick with for the development of the method, because most of the field of brain age right now is shifting toward more and more complicated methods using deep learning and adding functional MRI, DTI, structural MRI to the mix, even more and more complex data. And I wanted to use something very simple, just T2-flow MRI that we have. And Radiomics is supervised extraction of features, so it does not require a lot of computation. I'll run most of the computation on my laptop, and for inference for a single patient is very, very quick. So I would say, as of today, extracting radiomics for a patient and then predicting brain age probably takes a bit less than a minute. The complex part comes from the segmentation of the brain, which is a prerequisite to extract the features.
Hey, I have one quick question, John, if it's okay. Given legalization of marijuana all over the place, any effects of just now more excessive use of marijuana as a recreational drug on brain age?
So I've not seen anything on that topic, particularly for marijuana. All I've seen were association with tobacco consumption. So especially from people that analyzed, I think, the UK Biobank cohort, if you want to look into it in that part. But I don't think they have data on marijuana usage. Thank you.
Great. Well, Martin, thank you so much. It's a terrific talk. Paper is very exciting, and we look forward to hearing from you again. This is obviously a topic of great interest to the McCance community.